Hello and welcome back to Unacademy. So let's get NEET PG. Myself, Dr.Muskan, and today we'll discuss about the leftover the arbovirus, and we have already discussed about the this dengue and Japanese encephalitis. So rest of the arbovirus and the Picorna virus, we'll discuss about them, and we'll do the question answers related to them. So starting with the class, myself Dr. Muskan Chaudhary, your NEET PG and educator for the microbiology subject. On the plus category, we get access to both the live and the recorded sessions and learning from the India's topmost educator for any medical examination, be it in medical or other engineering paper. So competing in the live T&Ds and studying on the device of our choice, assessing up to 25,000 of the MCQs with the printed and the digital notes. Under iconic subscriptions, Prep Letter has come together with Unacademy, where we get access to clinical and integrated essentials with video lecture QBanks and the rapid revision snapshots with 2022 Dream Notes. With well-structured live batches, recorded sessions, QBanks, competitive T&Ds, and digital notes. Under plus category, NEET PG plus category for 24 months for 2 years, it is around 36,000 rupees, accounting for around 1500 per month. And for 3 years, it is 1250 and 1625 for 18 months. For NEET PG iconic subscription, for 2 years, it is 58,500. For 2 years, it is 24381875 and 2875 for 18 months. Please do use my code that is Muskan10 to get 10% of the discount. With highly effective and updated Q banks, we have 25,000 of MCQs based on latest examination pattern and the detailed explanations. Special class features includes the interactive live classes, do the polling for the learners, respond to the polls for a better understanding of the topic, raise a hand because talk to educator and get your doubts resolved that too within real time. Never miss a class because you will get the notification for the same before starting of the class on the YouTube as well as on the app. Download the lecture notes and get access to recorded sessions of the live classes anytime and anywhere. Now, very important announcement is that on the 19th of the December, that is on the 19th at 5 p.m., we are having the NEET PG Combat. If you do remember, we have NEET PG Combat every month, and it is purely a scholarship-based program where the on the basis of your NEET PG ranking. In the test, you will be getting the scholarship. If you rank between rank 1 to 3, it will be 100% scholarship, and rank 4 to 10, 75%. Between 11 to 15 will be 50%, and 51 to 200 will be 25% of the scholarship. So practice and enhance your prep with Unacademy and get real-time all India rank with the detailed solutions of the same by the top educators, and you will be getting the questions this time from the community medicines, ENT and ophthalmology, and win up to Amazon vouchers up to rupees 10,000. So target NEET PG 2022 TND batch includes from the 15th December, and it will be duration of 3 months by the topmost educators with well-structured batches, modules, and the grand test clinical integrated approach with the live sessions and recorded sessions if you miss the live in case of students who are not able to keep in touch with the live sessions. So with 24 month subscriptions, we get 4 month totally free, and with 12 month subscriptions, 2 month totally free, and with 6 month subscriptions, 1 month subscription totally free. That is valid from the December 14 and till December 15. So that was till yesterday, that was valid. Now, PG test, we are having the December 2021 free test rituals where you'll get the test series and the grand test. And this is a schedule for the same. That is, every Wednesday at 9 p.m., you will be having the educator curated test series. And every Wednesday, 9 a.m. and 2 p.m., you will be having the grand test for the FMGs. Study with us on the YouTube test series on the Friday, and on the Saturday, you have the special class marathons at 9 p.m. And on the Sunday at 9 a.m., you have the grand test series for the all examination with Central Institute, with NEET PG or FMG. So this is a schedule and keep it in mind. And for the plus batches, we have the special classes for the plus batches that is on Saturday, Sunday, and on the Sunday at 10 p.m. So for the NEET PG, FMG, and the 2023 system-wise test series. And please do use my code that is Muskan10 to enroll into the same and to use the subscriptions by the Unacademy. So this is the FMG 2022 batches with a 6 month that will be a schedule, including the live classes, recorded classes, PDF notes, practice sessions. So we'll start with the first virus of today's first arbovirus. So we'll study about the chikungunya. We did study about the dengue in the previous class, and we did study about the Japanese encephalitis in the last class. This time we'll study about the chikungunya. If you remember, for the chikungunya, for the yellow fever, and for the dengue, we had the same vector mosquito, that was the Aedes, and that is the tiger mosquito. We also saw the pic for the tiger mosquito, that is having the patches similar to that of the tiger on the limbs. So that is the Aedes mosquito. So, chikungunya, the symptoms that the patient will present is that patient will present with a fever, rash, and the lymphadenopathy with the arthralgia. Now, name is derived, that is doubled up due to the joint pain. It differs from the dengue that hemorrhagic manifestations are that the chikungunya outbreaks are shorter when we compare that to that of the dengue, and the vector is the same, that is the Aedes aegypti for the chikungunya, gunya for the yellow fever, and for the dengue. All right. Now we had the first outbreak in the Africa, and then in the India in 1964. With from the 1973 till 2005 we had no outbreaks. Then we had the re-outbreak in 2005 in India, and that is starting with the Hyderabad, Karnataka, and the Maharashtra. All right, previously it was the Aedes aegypti that was the main factor for the transmission of the disease, and in case of the outbreak we had the re-emergence from the new vector, that is the Aedes albopictus. Now, this is a vector that I was talking about, the Aedes aegypti, that is the tiger mosquito. You can see the patches on the mosquitoes. Now, a viral factor, that is even glycoprotein mutation of the virus, and this is the reason that it is the mutation of the virus. Glycoprotein is responsible for the re-emergence of the disease. Now, coming to the next one, yellow fever. Now, yellow fever is endemic in the Africa, that is the West Africa and the Central South American. All right, reservoir are the monkeys, forest monkeys. It is important. The reservoirs are the forest monkeys and the forest mosquito. In the urban, we have the reservoir. That is one is the important one, that are monkeys, as well as the mosquito, that is the same, that is the Aedes. Then in case of the urban cities, we have the reservoir as the cases itself and the Aedes aegypti. It doesn't exist in India. The yellow fever is not present. This is also an important question, that which of the following virus is not found in India. We doesn't have the yellow fever in India because Aedes is present in the east coast area in India, where yellow fever is endemic in the West Africa. Strict vigilance and the quarantine for the travelers. Therefore, cross-reacting of the dengue antibody provides the protection, but yellow fever immunization doesn't protect from the dengue. So that is the reason that in the India the yellow fever is not existing. The reason being that we have the strict vigilance and the quarantine for the travelers who are visiting India, and the immunization against the yellow fever doesn't is not protecting against the dengue. Now, next is that the incubation period is about 3 to 6 days. Period of communicability. Period of communicability is the first 3 days of the illness, that is can be infected to the mosquitoes, and the lifelong mosquitoes are lifelong infectious to the men. Clinical features we have similar to that of the dengue. We have the hemorrhage, we have the platelet dysfunctions, and important one, that is the relative bradycardia and the jaundice. Next is the liver. In the liver, patient will present with the mid-zonal necrosis, and very important inclusion bodies that we need to remember are the Councilman's bodies. Other than this, we have the Taurus bodies, these are intranuclear inclusion bodies. And it is a highly fatal, that is case fatality rate is up to 80%. Is up to 80%. So case fatality rate is up to 80%. And liver, we have the Councilman's bodies and the Taurus bodies. These are intranuclear inclusion bodies. This is a list of the inclusion bodies, very important. So most major inclusion bodies are intracytoplasm, but we have two viruses, that is one is the cytomegalovirus and the measles, where the inclusion bodies are what the both intranuclear as well as intracytoplasmic, that in the CMV and in the measles. Other than this, HB bodies in the molluscum, negri bodies in the rabies, guarneri bodies in the smallpox, pastin in the smallpox, Bollinger and the Borrel in the fowlpox. Then we had the Cowdy type A and the B. How we remember the A? That is the Hay. That is H for herpes simplex, Y for yellow fever, having the Cowdy type A inclusion bodies along with the VZV, and the Cowdy type B that is present in the polio, ateno, and the CMV. This is the council men's body found where in the liver, and it shows the ballooning degeneration. Ballooning degeneration. You can see the ballooning degeneration, that is the councilman's body found where in the liver, and we also see that in the acute hepatitis cases. So acute hepatitis cases, the virus causes the hepatocellular injury, and this is the ballooning degeneration, councilman's body, bridging necrosis, Kupffer cells hyperplasia. Now, what will we do for the prophylaxis of the yellow fever? Now, one is the vaccine, that is the Dacre vaccine. One is the vaccine, that is the Dacre vaccine, that is the mouse brain derived vaccine, having the risk of encephalitis. Okay, so that is the Dacre's vaccine, and the 17D A28 vaccine that is prepared in India, prepared from the chick embryo with no risk of encephalitis. So one we have the Dacre vaccine that is having the risk of the encephalitis, and more preferred one is 17D live vaccine that is more preferred because of the no risk of the encephalitis, and it is lyophilized vaccine with the cold temperature that is maintained -30 degree to the 50 degree Celsius, reconstituted with the dilutants that we use the saline and should be used within half an hour, given single dose, that is subcutaneously, effective within 7 days of inoculation, and last up to the effectivity will last up to 35 years. Validity for the yellow fever certificate is issued after 10 days, and reimmunization is required. That certificate is renewed every 10 years for the international travelers. Cholera and the yellow fever vaccine should be given together, 3-week gaps to be maintained. So we use remember the name that we use the Dacre vaccine and the 17D vaccine. Prefer the 17D vaccine because of the no risk of the encephalitis, and we use the diluent, that is saline, given subcutaneously within used within half an hour and given subcutaneously. Contraindication are the children who are less than 9 months, and in case of the epidemic 6 months. Pregnancy is also a contraindication but can be given in the pregnant woman in case of the outbreaks or epidemic. HIV people and the people who are have the allergy to that of the egg. So these are the contraindication. One is the children less than 9 months of age, pregnant women except the outbreak, people with the HIV and having the allergy to the egg components. Measures in the airport that is taken is that unprotected travelers, they are given the 6 days of the quarantine, and we have the Breeder index, that is the Aedes aegypti index. We'll check on that. What is that? So that was about the yellow fever. That is endemic in the Africa. Reservoir the monkeys and the mosquitoes, and it is not present in India. And the period of communicability is up to from the men, that is first 3 to 4 days of illness. Now mosquito is the lifelong infectious to the man, and we have the councilman's bodies, Tories bodies, and the councilman's bodies is the ballooning degeneration, and we have the Dacre's vaccine and the 17D yellow fever vaccine that is prepared from the chick embryo. So the people who are allergic to the egg are not given. The risk of encephalitis is not there, and reconstituted with the saline used within the half hour if opened and given subcutaneously. Effects last up to 75 years. Then we have the we have the some indexes, that is one is for the Aedes aegypti, that is one is the house index or the premise index. So what is house index? House index is the number of house for the Aedes species upon number of house that has been inspected for the Aedes. All right. What is the container index? Number of container. It is from the name itself, houses, that a number of houses upon total number of house that has been inspected. Container, total number of the containers upon the containers that has been inspected for the mosquito. And next is the Brito index, that is the number of the positive containers on the total number of the house that has been inspected into the 100. So Brito index is important. Hmm. Now, coming to the next one, that is the KFT. Now, KFD is also known as the monkey's disease. KFD is also known as the monkey's disease, and it is also responsible for the hemorrhagic manifestation. We had for the hemorrhagic manifestation, we had the yellow fever, we had the dengue, we are having the KFT. Incubation period is 3 to 8 days, and KFT, very important question, that is the tick borne. And that is in India, it is hard tick. And we talk about the other countries, it is the soft tick borne vector. Okay, said, and what are the reservoirs? Reservoirs are the rats and the squirrels. That is the KFD reservoirs are the rest, and the amplifier host, again important amplifier host for the Japanese encephalitis. We were having the pigs and the bats. For the KFD, that is a monkey's disease. Therefore, the amplifying host is the monkeys, and the vector is the tick. That is a soft tick in case of the world, and in case of India, it is hard tick. Man is an incidental host and a dead end host. Man is not a definitive host. Seasonal, that is the dry month, that is a Jan to June, coincides with the human activity in the forest. Seen in the Mysore forest, that is the Kayasanu forest, that is in the Karnataka. Endemic in the four districts of the Karnataka, that is Shimoga, North Kannada, and South Kannada, and the Shika, Mangalore. Largest outbreak in 84, that is only focal cases, and control measures, that is a killed KFD vaccine and as well as the vector control. So KFD monkey disease reservoirs are the this rats, and the monkeys are the amplifying host. Man is the dead end host or the incidental host, and it is a soft tick and the hard tick born. In India, it is a hard tick. Now, incubation period for all the disease, that is important. For the dengue, it is 5 to 6 days. For the chikungunya, it is also 5 to 6 days. For the Japanese encephalitis and the vector, if you remember, that was the Culex mosquito, 5 to 15 days. Then we have the yellow fever, that is 3 to 6 days, and the KFT, that is 3 to 8 days. So yellow fever 3 to 8 6 days, KFT 3 to 8 days, and dengue and chikungunya, that is the same, and the Japanese, that is 5 to 15 days. So dengue, chikungunya, yellow fever, what was the vector was the Aedes, and for the KFT, the vector is the hard tick in case of the India. In case of the world, it is a soft tick. Then we have the Japanese encephalitis, that is a Culex mosquito. Now, coming to the hemorrhagic viruses, now non-arthropod virus. Now, first we'll come to the hantavirus. So, hantavirus, that will have the presentation with the hemorrhagic fever with the renal syndrome. This is a rodent born. This is not a vector born. Therefore, it is not a true arthropod. We do have the question that which of the following is a true this arbovirus. So, one of the option is also hantavirus. It is a partial arbovirus considered because it is not a mosquito-borne vector disease. It is a rodent-borne that acts as a vector. Most common route is by the inhalational route by the excreta of the rodents, and responsible for causing the pulmonary syndrome by the virus. Now, next we'll discuss about the Picorna Viride, that is includes two major groups. One, we have the enterovirus, and next we have the rhinovirus. In the enterovirus, we'll today discussed about the polio and the Coxsackie A and B, ecovirus, and the enterovirus. Next, we have the rhinovirus, that is the most common cause of the cold. and has the 100 serotypes. So we have the hemorrhagic virus, that is a hantavirus, hemorrhagic fever with the renal syndrome, that is a rodent-borne, and the hentapulmonary syndrome. Picorna Viride having the two subfamilies, that is the antro and the rhinovirus. Rhinovirus responsible for the cold and most common cause for the common cold. And the enterovirus, we have the polio, we have the Coxsackie and the eco as well as the enterovirus. So starting with the first, that is the polio virus. We'll complete the polio and the Coxsackie and rabies in the next session, and we'll do the question answers for the same. Yes. So polio viruses, we have three subtypes. That is type 1, type 2, and type 3. So type 1, that is most common wild type, and it is responsible for causing the epidemics. Then we have the type 2 that causes the endemic. Then we have the type 3 that is the most common for the vaccine associated polio. So we have the three subtypes, that is the type 1, 2, and 3. Type 1 is responsible for causing the epidemics. That is the most common wild type. Then we have the type 2 that is responsible for causing the endemic, and it is most easily eradicable. Then type 3, that is a form of vaccine associated paralytic polio, that is a VAAP. So we have the VAAP, that is a vaccine associated polio, paralytic polio, that occurs around 4 cases for 1 crore people, and most common serotype that is associated with the VAPP is what? 7-3, more than 2, more than 1. VAPP occurs to recipients of the OPV as well as to other contacts as well. So we have the three subtypes, that is 1, 2, and 3. One is the most common for the one is the most common. That is type 1, 2, and 3. Type 1 is responsible for the epidemic, type 2 for the endemic, and type 3 for the VAP. Okay, so we have the vaccine associated paralytic polio, that is 4 cases for 1 crore people, and the most common serotype is 3, then 2, then 1. Antigens, two antigens detected by the complement fixation test. That is, one is the C antigen, that is the codeless antigen, and then we have the T antigen, that is the dense antigen. So we have the C and the T antigens. Now, what are the risk factors for the polio? That is, after following the tonsillectomy, after pregnancy, this during pregnancy, IM injections, muscular activities, Coxsackie A, genetic predisposition, and alum containing the DPTs. Pathogenesis mode, most common mode of transmission is fecal-oral route. We do have the inhalational route as well, and this is also a question. And next is the conjunctiva. Okay, so mode of the transmission is the fecal-oral, then we have the inhalation and the conjunctival route. Coming to the spread, most common, this hematogenous spread is the most common, and as well as the direct neural spread following the tonsillectomy. So when we talk about the spread, it is hematogenous spread, that is the most common, followed by the direct neural spread. Site of the action is the anterior horn of the spinal cord. Earliest change in the neuron is the Nisi body degeneration. Pathological change is always more extensive than the distribution of the paralysis. Epidemiological features, we have the reservoir as the man and no chronic carriers. We have the clinical subclinical ratio for every clinical to subclinical cases. We have 1,000 children and 75 adults. Infective material is the stool and the oropharyngeal secretions, and the period of communicability is 7 to 10 days before and after the onset of the symptoms. Clinical types in the apparent infection, that is the 91 to 96%. Abortive infections, we have 4 to 8%, and aseptic meningitis 1%. Paralytic cases, we have less than 1%, and descending asymmetrical acute flaccid paralysis will show that one is the tripod sign positive, decreased DTR, cranial nerve involvement, and but no sensory loss. Paralysis includes more the proximal muscles more than that of the distal muscles, and starting at the hip and moving to the extremity. So this is a sequence that paralysis. The first is the proximal, then we have the distance muscles involvement starting at the hip and to the extremities. So the typical contractures of the polio, we have the callus on the knees from the groveling, and we have the equinus deformities of the ankle, flexion, abduction, contracture of the hip, and the flexion, contracture of the knee, valgus deformity of the knee and the leg, and the varus and the valgus deformity of the foot. Now, coming to the lab diagnosis for the blood, that is third to fifth days, and throat swab and the feces, that is first week till the sixth week. Isolation monkey kidney tissues, we do the MKC monkey kidney tissues in the isolation, and the stool culture that is recommended for the AFP and the lab confirmation. Isolation stool doesn't correlate with the disease as shedding occurs in the subclinical cases as well. Neutralizing antibodies come early and stays long, and by the CFT antibodies, that is anti-C and anti-D, we check for the anti-C and anti-D because anti-C comes early as well as goes early. Anti-D comes late as well as go late. So CFT antibody we check for the anti-C and anti-D. For the neutralizing antibodies, we that is a comes early and stays low. And isolation in the stools, that is, but it is not reliable as it doesn't correlate with the disease as the shedding occurs even in the case of subclinical cases. So starting with the Salk and the Sabin vaccine, that is the IPV, that is the Salk, and the oral poliovirus, that is the Sabin. Since it is a oral, so it is a live vaccine and mostly used in the developing countries, and it limits the multiplication. It provides a local immunity or the mucosal immunity, so limits the multiplication of the wild poliovirus in the intestine, and therefore reduces the fecal transmission. Cheap and easy, and side effect is that VAPP, that is a vaccine associated paralytic polio. SOC, then we have the inactivated or the killed, that is injectable, and in the developed countries we use and prevents the spread of the polio virus to the nervous system. No shedding of the vaccine virus occurs, while shedding occurs if the virus leads to the control of the epidemic in case of developing countries. A SOC is the costly one and with the no side effects. Now, one more thing is that when we talk about the Salk vaccine, when we talk about the IPV, it is a formalin killed. It is a formalin killed preparation. Is the Salk vaccine, that is the IPV. Now, it is a formalin killed preparation in the monkey kidney cells, and we use total 80 units of D antigen of type 1, 2, and type 3. So, Salk vaccine, that is the IPV, that is the inactivated killed vaccine, and formalin kill preparation. Total 80 units of the D antigen of type 1, 2, and 3. We have 4 doses. First 3 dose at 1 to 2 month gap. Fourth booster after 6 to 12 month gap. It is relatively more safer than that of the more safer as well as low risk vaccine compared to that of the oral poliovirus. Efficacy is about 80 to 90%. By the full immune course, the vaccination is effective up to 90%, but it is relatively expensive and the duration of protection is also short, therefore, booster is needed. Alright, so that is a soft vaccine, that is a formalin killed vaccine. From the MKC total, we use 80 units of the D antigen from the type 1, 2, and 3. And first 3 doses are given 1 to 2 months of the gap, with the fourth at the 6 to 12 months of the gap. But it doesn't provide no herd immunity. Used where in the developed countries and do not require stringent conditions for the storage and no risk of VAPP. So we have the Salk vaccine, that is a formalin killed vaccine, and a total 80 units. First 3 doses given at the 1 to 2 months of the gap, with the fourth at the 6 to 12 month booster. More safer, used in the developed countries and expensive, but no herd immunity is provided and doesn't require the strict storage conditions, with no risk of the vaccine associated paralytic polio. Now talking about the Sabin or the oral polio vaccine. Each dose contain TCID 50 of type 1, 2, and type 3. Here total 5 doses are given, that is 0 dose given at birth, first, second, and third at 6, 10, and 14 week, and the booster that is given at 16 to 24 month of age. So we have the OPV, that is a 6, 10, 14, and 16 to 24 month we are given the booster with a 0 dose given at the birth. Safer but not in case of the immunocompromised, because it is an oral polio vaccine, or in case of the pregnancy, or in case of the old age people. Efficacy is up to 90 to 100% by only first or the second dose. It is highly efficient and it is economical, used mainly in the developing countries. Risk of VAPP, and the storage condition requires sub-zero temperature, that is minus 20 degrees Celsius, stabilized in MgCl2, maintaining the pH less than 7. So that is the oral polio vaccine providing the herd immunity as well, because the vaccine is being shedded in the species of the people who are vaccinated. So that is the oral polio vaccine providing the herd immunity, as well as total 5 dose given, 0 dose are given at the birth. Then we have the 6, 10, and 14, and boost at 16 to 24. Safer but not given case of the immunocompromised or the pregnancy in the old age people, effective up to 100% just by the first and the second dose. Economical, used in developing countries, with the but having the risk of the VAPP. Storage requires the stringent condition, that is at minus 20 degrees Celsius and stabilized in the MgCl2 with maintaining the pH less than 7. Now moving next. We've already seen the Salk and the Sabin vaccine, that is the OPV live vaccine given orally. Therefore, immunity is both humoral as well as intestinal, prevents the paralysis, can be effective in controlling the epidemics by the herd immunity, easy to manufacture, therefore cheap and used in developing countries, requires a sub-zero temperature, that is minus 20 degrees Celsius, stabilized in MgCl2, and pH is maintained less than 7. IPV is a killed vaccine given SC or IM, induces circulating antibodies, prevent the paralysis, not useful in controlling the epidemics, used in developed countries. It is costly and doesn't require the stringent conditions, and doesn't causes the VAPP as well. Now coming to the vaccine vial monitor, important one by the peer community medicine point of view as well. So vaccine vial monitor, that is a tool to monitor the stability or to see the potency of the vaccines, and here we're talking about the OPV. So it is a heat sensitive label lining the OPV. We have this vaccine and we have the vaccine vial monitor. Outside the vaccine container contains a ring of the two circles. Outer circle is blue and the inner circle is white. WHO grading, what does it say is that outer circle remains blue always, but inner circle may be white or changes to light blue, dark blue, or even black. OPV is usable up to grade 1 and 2 but discarded after grade 3. Now, starting with the grade 1, grade 3 and 4. What does the grade means? That the inner square is lighter than the outer circle. Here also the inner square is lighter. So these two vaccines are usable and expiry date has not been reached yet. Now the inner square and the outer circle has been merged. We do not use the vaccine. And similarly for the fourth one, when the outer circle color is lighter than the inner square, do not use the vaccine. No natural cases are reported since 2011. Few cases of the VAPP and VDPs have been reported even till date. Type 2 is not reported since 1999 and type 3 is not reported since 2012. So we are currently having the type 1 that has been being reported. Now coming to the next immunization program, that is a pulse polio immunization. Now, sudden simultaneous mass administration OPV in a single day to the children, all the children who are aging less than 5 years of the age, that is a pulse polio. Now irrespective of their OPV, irrespective of their previous schedule of the OPV, coverage is done by the national immunization schedule and extra doses, and doesn't replace the doses of the national immunization schedule. So it is a simultaneous mass administration to all the child who is less than 5 years, and irrespective of the previous NIS schedule, we do give the polio OPV. There is no minimum interval of the PPI and dose of the national immunization schedule. Mopping up is a door-to-door immunization of the high-risk districts, that you must have seen that as well. Now, move to the next one and the last topic of this session, then we'll do the question answers. So that disease that are caused by the Coxsackie virus, that is the herpangina, that is the Coxsackie A virus. Then we have the A16, that is the hand, foot, mouth disease. Hand, foot, mouth disease. We have the Coxsackie A16, and enterovirus 71. Then we have the pleurodynia coxsackie B virus, myocardial pericardial infections by the B, and the viral meningitis. Coxsackie viruses are a part of the entero family viruses and include the polio and the hepatitis A viruses that live in the human digestive tract. They can spread from person to person, usually on the unwashed hands and surfaces that are being contaminated by the feces where they live for the several days. Coming to the pathophysiology, they are transmitted primarily via the fecal-oral route and the respiratory aerosols. While fomite transmission is also possible, the viruses initially replicate in the upper respiratory tract and they have been found in the respiratory tract up to 3 weeks after the initial infections. They also replicate in the submucosal lymph tissues. Further dissemination to target tissues occurs after secondary viremia. We have the hand-foot mouth syndrome that is why it caused by the Coxsackie A16 as well as enterovirus. So, type of the Coxsackie virus syndrome and cause a painful red blisters on the throat, tongue, cheek, gums, hand, as well as the feet. That is a hand, foot, mouth disease causing the painful blisters on the mouth, tongue, throat, gums, cheeks, as well as the hands and the feet. Okay, so we'll come to the first question of the today's session now. Okay, so which of the following arbovirus disease is not found in India? That is a sandfly fever, Rift Valley fever, West Nile fever, or the yellow fever. Yes. So which of the following arbovirus disease is not found in India? Now, when we talk about the sandfly fever, that is also known as the 3-day fever and caused by the phlebotomus and Rift Valley fever, West Nile, and the yellow fever. We already know that yellow fever is not found in India. It is majorly found where? It is found in the Africa. It is found in the West Africa and the Central South America. But it is not found in case of the India as well as the Rift Valley fever that is also not found in India. Incubation period for the yellow fever is 3 to 6 days and 3 to 4 days, 1 to 2 days, 1 to 2 weeks or 8 to 10 weeks. What is the answer? We had the incubation period for the yellow fever and for the chikungunya fever. That was same if you remember the incubation period for the yellow fever as well as for the chikungunya. Is what is the answer? That is 3 to 6 days. That is 3 to 6 days. Now, according to the International Health Regulation, yellow fever transmission risk is minimum if Aedes aegypti index is less than 1%, 5%, 8%, or the 10%. So what is the answer? Now, according to international health regulations, we talked about an index, that is the AA index, that is the Aedes aegypti index, and that is what is the other name? That is the Brutio index. That if you remember, that is a number of the positive containers upon number of the house that has been inspected into 100. That was the index that we did to see for the Aedes aegypti, and that should be less than 1%. That should be less than 1%, and within 400 meters of airport. Within 400 meters of the airport. Okay, that should be less than 1%. All are true about the yellow fever. All are true about the yellow fever, except that belongs to the flaviviridae. Vaccination is valid after 10 days and lasts after for 10 years. Incubation period is 16 to 46 days, and case fatality rate is 80%. So all of the following is true except. Now all are true except now belongs to the flaviviridae. This is true. Vaccination is valid after 10 days and lasts for 10 years. This is also true. And incubation period, if you remember the vaccination for the yellow fever, one we had the 17-day yellow fever vaccination, and other we had the Decker vaccination, that but it had the risk of the encephalitis. Therefore, we are not using that. We are using the 17-day vaccination that is given subcutaneously and given a single dose. Incubation period is 3 to 6 days that we just did, that the incubation period for that of the yellow fever, and case fatality rate is 80%. This is also true because yellow fever, although it is not found in India, but is highly fatal, having the case fatality rate of up to 80%. Now, Yellow Fever Referral Center India is Hafkin Institute Mumbai, or the Center Research Institute Kasuli, AIMS Delhi, or the NIN, that is the in the Hyderabad. Now, reference institute for the yellow fever in India, is Center Research Institute Kasoli, where 17-day vaccination is prepared. Alright, other than this, we also have the National Institute of Virology, where in the Pune. Yellow fever vaccine is 4D, 5D, 2D, or 17D. For the yellow fever, we have two vaccines. One is the darker vaccine, and another is 17D vaccine. That is the 17D live attenuated vaccine. Darker vaccine is a mouse derived vaccine having the risk of encephalitis, while 17D has no risk of encephalitis given subcutaneously, and one dose given, that we are talking about the 17D vaccine. Which of the following statement is true regarding the arbovirus? That yellow fever is endemic in India. Dengue fever has only one serotype. KFD is transmitted by the ticks. Mosquito of the Culex vishnoi complex is the vector for the dengue fever. Yes, pretty simple one. Which of the following is true? Yellow fever is not found in India, therefore, how it can be endemic? Dengue fever has no, it has the four serotypes, and fifth one is also there. KFD is transmitted by the ticks. In India, it is majorly the hard tick that is responsible as a vector, and in case of the world, we have the soft tick. And now, Culex mosquito is the vector for the Japanese encephalitis, not for the dengue. For the dengue, for the yellow fever and chicken gunya, we have the Aedes, that is a tiger mosquito. This is how we write J, and this is how we write the C. That is the Culex mosquito is the vector for in the case of the this. Japanese encephalitis. Which of the following is not useful for the prevention of the KFT? That is a vaccination, deforestation, prevention of the roaming cattle, or the personal protection. So if you remember that KFD is transmitted by the tick, that is by the hard tick and the soft tick. Hard tick in case of the India and the soft tick in the rest of the world. So which of the following is not helpful in the prevention? Now, what are the measures? What are the measures to control the KFT? Either to control the vector measures, either to have the vaccination that we have the killed KFT vaccine. Other than that is the personal protection. Personal protection, that is by using the tick repellent this ointment, that is by mosquito repellent ointment, that is the dimethyl halide. Now, since tick population, the forest is attributed for the to free roaming of the cattle. The restriction of the cattle movement is thought to cause the reduction of the this vector transmission. But deforestation anyhow is not useful for the prevention of the KFT. So either we can have the killed KFT vaccine, or we can have the personal protection. We can control the vectors, and we can do the health prevention of the cattle roaming. Now, vector for the cave is soft tick, mice, housefly, and the lice. So this is pretty simple one. We know that the vector for the KFT is for the soft tick. Now, which of the following statement is true? That hantavirus pulmonary syndrome is caused by the inhalation of the rodent urine and the feces. KFD is caused by the bite of the wild animal. Lyssa virus is transmitted by the tick, and the yellow fever is endemic in India. So, which of the following statement is true? So coming to each of the option, which of the following statement is true? Yellow fever is endemic India. No, yellow fever is not found in India. Lyssa virus, that is a rabies virus, is transmitted by the tick. It is transmitted by the infected bite of the dogs. So this is also not true. KFD is caused by the bite of the wild animals. No, it is caused by the bite of the hard tick. So hantavirus. Mhm. Hantavirus pulmonary syndrome is caused by the inhalation of the rodent virus. This is true because hantavirus is a natural host. This rodent is a natural host for the hantavirus, and it shows the viremia in case of the rodents. And human gets by the inhalation of the feces of the excreta of the rodent's urine and the feces through which the person get infected. So this is the true statement. True about the hantavirus is that it is a PJ, more than one will be correct. Hantavirus pulmonary syndrome transmitted by the arthropod, transmitted by the rodents, and the hemorrhagic fever with the renal failure. So, which of the following statement is true? So which of the following statement is true? Hantavirus responsible for HPS, that is a hantavirus pulmonary syndrome. This is true. Transmitted by arthropod? No, it is transmitted by the rodents, and the infection is inhaled by the rodent's feces and the urine. Hemorrhagic fever with the renal failure is also a true statement. Now moving to the next one. Which of the following is not a vaccine-derived poliovirus, that is AVDPV, CVDPV or MVDPV or IVDP and MVDPV? Now, when we talk about the vaccine-derived poliovirus, that can be categorized into the CVDPV, that is the circulating VDPs, and these strains are capable of person-to-person transmission in the community and can cause the outbreak in the area with low OPV coverage. So we have first is the CVDPV, that is circulating vaccine, that poliovirus, and where the person to person transmission is possible, and they can cause the outbreak in an area if there is a low coverage of the OPV. Okay, now next we have the IVDPVs, that is the immunodeficiency associated VDPVs, that are isolated from the people who are primarily immunodeficient and having the immunodeficiency disorder. Then next we have is the ambiguous VDPVs, that is the AVDPVs. These are heterogeneous and they are either CVDPVs for which only one case isolation has been seen, and they may be the sewage isolates obtained from the developed countries. So we have the mainly three generation, that is the three categorization of the VDPs. One is the CVDPV, that is a circulating one, and in the areas where is a low coverage of the OPV, there is person to person transmission seen. So this cannot be the answer. Then next is the MVDPV, where we have the this one VDPV, that is a immunodeficient VDP seen in the immunodeficient people or having any disorder. Now next is the AVDPV, that is the ambiguous one, that is a heterogeneous one. So we do not have the this MVDPV. Now polio is still transmitting in the India, Pakistan, Nigeria, Afghanistan, and Sri Lanka. Again, more than one option will be correct for this one. So polio is still transmitting in. Now, easy to remember, we doesn't have the India. That is, we have the NAP countries, that where the still polio is there. That is a Nigeria, A for Afghanistan, P for Pakistan. So NAP countries, they are still having what? Polio virus circulating. True about the polio eradication initiative in India is that last natural case was due to wild virus was reported in 13 January 2011. No case of vaccine-associated palliative polio was reported from the 2012. India is the only country that has not achieved the goals of the polio eradication. Currently, the vaccine used for polio eradication in India is IPV. So, which of the following is true statement? So coming to the options now. Now currently the vaccine used for the polio eradication in India is not IPV, it is OPV. So this is not true. India is the country that has achieved. So it is written that India is the only country that has not achieved. No, India has achieved and has been removed from the endemic countries list. Now one case of the VAP was reported in the 2012, that was in the West Bengal, and the last natural case due to the wild virus was reported in 13th of January 2011. This is the true statement. Now, false about the polio, descending paralysis, non-progressive, bilateral symmetrical, and the element type of paralysis. So, talking about the polio virus, talking about the paralysis by the polio. Now, paralysis in the polio is descending, progressive. So, descending, progressive, asymmetrical, acute, flaccid paralysis. Okay, that is acute flaccid paralysis. That is a descending but progressive asymmetrical acute flaccid paralysis. Paralysis is more common the high risk people, that is older age group or the pregnant woman, person who is exercising, and what is the people with the underlying CNS symptoms or any other disease. So we are having the polio, that is a descending acute flaccid paralysis, progressive and asymmetrical, and that is in the mainly in the age group, that is the older people and the pregnant women who are extensively exercising, with another risk factor is the CNS symptoms. Now, other than this, we have the people who has undergone the tonsillectomy. And what else we see? We see the, in case of the paralysis by the polio, that is a tripod sign positive, decreased DTR, cranial nerve involvement with no sensory loss, with no sensory loss. So the question must be about true about the polio virus, that is the descending paralysis, that is the progressive, that is the symmetrical, and with the no sensory loss. And what is the sequence of the paralysis? That is from the proximal and to distal, and that is legs more than that of the arms, and it starts with hip and move to that of the extremities. So that is a polio, that is acute flaccid paralysis, descending and the progressive one, and asymmetrical one. People with the older people, pregnant women, and the CNS symptoms tonsillectomy with the positive tripod sign, and the proximal more than involvement more than that of the distal, with the legs more than involved than that of the arms, and starting at the hip moving to the extremities. Now, moving to the next question. Diagnosis of polio is detection of the polio virus in the stool by the serology, by the limb wasting, or the acute flaccid paralysis. Yes. Now, for the diagnosis of the polio, serology, limb wasting, and the AFP. This is not relevant because limb wasting and the AFP has been seen in other diseases as well. We go for the detection of the polio virus directly in the stool, directly in the True. True about the poliovirus. True about the poliovirus. Paralytic polio is most common. Spastic paralysis, IM injection increased muscular activity leads to increased paralysis. Polio drops given only in less than 3 years. So, which of the following is true about the poliovirus? So now coming to each of the statement individually. Now paralytic polio is not common. It is found in only less than 1% of the cases. It is found only in less than 0.1% of the cases. So this is not true that it is common. We have the acute flaccid paralysis. Acute flaccid paralysis is also not true the spastic paralysis, because you have just seen that polio virus present with a descending acute flaccid paralysis that is non-symmetrical. Polio drops is given to less than to all the children who are less than 5 years. Also, one of the risk factor for the apart from the old age pregnancy, CNS symptoms, or the with that of the increased exercise, and we have the tonsillectomy. IM injection can also increase to increased paralysis. Now, moving to the next question. All of the following statements are true regarding the poliovirus, except it is transmitted by the fecal-oral route. Asymptomatic infections are common in the children. There is a single serotype causing the infection. Live attenuated vaccine produces the herd immunity. So, which of the following is not true? Yes. Now, all the following statements are true regarding, except it is transmitted by fecal-oral route. This is true. It is transmitted. Most common mode is the fecal-oral, followed by the inhalational, and then by the conjunctiva. So this is true. Asymptomatic infections are more common in the children. Yes, and the most common age group is the 6 month to that of the 3 year, where the asymptomatic cases are more. There is not a single serotype. There are three serotypes that are causing the infection, and the live attenuated vaccine produces the herd immunity, that is a local immunity, mucosal immunity, and that is responsible for the eradication of the this polio from the community. So which is not true? Option C is not true. All of the true except type 1 is responsible for the most of the epidemics. Very difficult to eliminate type 1. Type 1 responsible for vaccine, palliative polio, and type 1 most commonly associated with the paralysis. So which of the following is not true? So, which of the following statement is not true? Now, type 1 is responsible for the most of the epidemics we had type 1, type 2, and type 3. Type 1 was responsible for the epidemic, and type 2 was responsible for the endemics, and the type 3 was responsible for the VAP. That is a vaccine with parasitic polio. So type 1 is responsible for the epidemic. This is true. Very difficult to eliminate type 1. This is the wild type and it is very difficult. Yes, this is also true. Type 3 is responsible for the vaccine parasitic polio, and the type 1 is mostly associated with the paralysis. This is also true. So type 1 is responsible for the wild virus vaccine associated polio virus, and the type 3 with the vaccine derived polio virus. Now, going to the next one, which sample is recommended for the polio isolation? Stool, blood, throat, or the CSF? So, for the isolation for the polio, we go for the stool sample because there is shedding of the virus in given case of the subclinical cases, although it doesn't correlate with the disease because this is also seen in case of the subclinical cases, the shedding is also seen. But for the isolation of the polio virus, we go for the stool sample. Now, true about the side effects of the OPV is that VAPP is recipient of OPV, VAPP is contacts or recipient of OPV, Guillain-Barré syndrome, or the vomiting and the fever. So, which of the following is true about the side effects of the OPV? VAPP occurs in recipient of the OPV. This is true, and the vaccine-associated polio, paralytic polio, is also seen in the context of the recipients of the OPV. Zero dose of OPV is given before birth, at birth, when child is having diarrhea, or when child is having polio. So when we talk about the OPV, we have total 5 dose schedule. One we have the 0 dose, and other than this, we have the 3 dose that is given at first, second, and the third dose that is given at 6, 10, and the 14 weeks. Other than this, we do have the booster dose that is given at 16 to 24 of months. Yes. So what is that? The 0 dose of OPV is given at. So 0 dose of OPV is given at birth. Now, for every case of the polio, the subclinical cases to be estimated as 5,500 children and 50 adults, 750 children, 75 adults, 1,000 children, 50 adults, 1,000 children, and 75 adults. Yes. So for the every case of the polio, we have the clinical to that of the subclinical ratio. Following the polio infection, for every clinical, we have the subclinical cases that is the 1,000 children and 75 adults. Now, Magnesium plus plus is used. Magnesium as is used as OPV as an adjuvant, stabilizer, vehicle, or the preservative. Remember, we use OPV at a, a strict refrigeration condition, that is minus 20 degrees Celsius. We use MgCl2 and we have to maintain pH less than 7. So we are using the MgCl2. Why we are using? Because it is used as a stabilizer. Now, wrong about the Salk vaccine, that is prevents the paralysis, contraindicated in the low immunity, and not useful in the epidemics. Booster doses are required. So, which of the following statement is wrong? So wrong about the Salk vaccine is that it prevents the paralysis. This is true. It is contraindicated in the low immunity. Now, Salk vaccine is the inactivated vaccine. It is the IPV. So it is not contraindicated in the people who are low immunity. Sabine vaccine, that is the oral polio vaccine, is contraindicated in the people with the low immunity, immunodeficient or pregnancy, or having the this already having the tonsillectomy or IV doing the strenuous physical exercise, because we have the association with the VAPP. Now, not useful in the epidemics. This is true because we use the oral polio vaccine, that is in the for the herd immunity, because there is shedding of the virus in the stools, but not in case of the Salk vaccine that we use in the developed countries. Booster doses are required because efficacy is up to 80% in case of the without we give that booster. Now, that is a option B is not true. Now, coming to the question, false regarding OPV, it is interfered by the maternal antibody. In India, OPV is used mostly. It induces a circulatory antibody rapidly, and cross infection through stool of vaccinated child can produce the herd immunity. So, which of the following is false? Okay, now coming to each of the options now, we to detect the false statement. Now, it in India, OPV is used mostly. This is true. It induces a circulating antibody rapidly. This is also true, and providing the local or the mucosal immunity. Cross infections of stool of vaccinated child produces the herd immunity. This is also true because OPV, we give the OPV in the developing countries to get the herd immunity to break the cycle of the transmission of the polio virus, and it is not interfered by the maternal antibodies. It is negligibly be interfered by the maternal antibodies, and there is no such interference of the maternal antibodies with that of the OPV or the oral polio vaccination. So that is it for the today's session. Thank you so much, and I will see you again at 9:30 p.m. We'll again take a session for the virology PYQs we'll do, and we'll 2 3 sessions we'll take for the continuous marathon type of questions, that is the previous MCQs, and after that we'll start new topic. So that is it, and please do use my code, that is Muskan 10 to get 10% of the discount. And I'll see you soon. And please don't forget to enroll into NEET PG Combat Scholarship Program, that is on the 19th of December at 5 p.m. We'll get 45 questions for 60 minutes from the ENT ophthalmology and the PSM. So take care. And